everyone, in today's video I will be talking about prostatic tumors and I will be covering prostatic adenocarcinoma in detail. So let's get started. The prostate gland is about the size of a walnut and is located below the bladder and in front of the rectum. It is surrounded by a fibrous capsule with nerves and vasculature which is covered by a layer of fascia. The prostate anatomically can be divided into five zones: the central zone, the fibromuscular zone, the transitional zone, the peripheral zone, and the periurethral gland region. The transitional zone is more likely to have benign prostatic hyperplasia features in biopsy, and in peripheral zone we can encounter carcinomas more commonly. Coming to the histology of prostate. Prostate is formed of glands and fibromuscular stroma. The glands are lined by two layers of epithelium, or the basal layer and the secretory cell layer. There are presence of corpora amylacea as depicted in the image in the prostate. Coming to the classification of tumors of prostate. Here I have enumerated WHO classification of tumors of prostate, in which I will be talking mostly about adenocarcinoma of the prostate as it is the most common carcinoma of prostate. The adenocarcinoma of the prostate is most common malignancy in men and most common malignancy of the prostate gland. It is the second leading cause of cancer-related death in men. It originates from the prostatic secretory epithelium and has a variable natural history, slow and indolent course to fatal, rapidly aggressive and fatal course. Talking about the pathogenesis of adenocarcinoma of the prostate, there are certain factors which are implicated in the pathogenesis of adenocarcinoma of prostate, which include androgens, hereditary factors, environmental factors like Western diet, exposure to estrogens, and acquired or somatic mutations or epigenetic factors like MYC amplification, P10 deletion, epigenetic silencing of GSTP1, loss of P53 or RB function, and amplification of AR. Clinically, the patients are generally asymptomatically unless the disease is locally advanced or metastatic, often discovered following investigation of non-specific lower urinary tract symptoms. Digital rectal examination can be done where prostate is felt normal or may be enlarged, asymmetrical, hard, or have a palpable nodule present. Grossly, 70% of the adenocarcinomas of the prostate arise in the peripheral zone and are gritty and firm but may be difficult to discern from uninvolved prostate. Microscopically, there are crowded, well-defined glands to sheaths to single cells which lack basal layer. The nuclei is enlarged and the nucleoli is prominent, and perineural invasion can be seen. In 80% of the cases, PIN is associated with prostatic adenocarcinoma. Here I have shown a gross image of adenocarcinoma of the prostate. As you can see, I have rounded it out, but it is sometimes very difficult to differentiate it from the surrounding prostatic parenchyma. This is an image of adenocarcinoma of prostate on H&E stain, and you can see the crowding of the glands, lack of basal epithelial layer, and the prominent nucleoli in the large pleomorphic nuclei. In this image, I have shown the perineural invasion, which is commonly seen in adenocarcinoma of the prostate. Now talking about high-grade prostatic intraepithelial neoplasia. Well, in high-grade prostatic intraepithelial neoplasia or PIN, prominent nucleoli is visible at 200x or lower magnification. In this, medium to large ducts and acini with enlarged hyperchromatic nuclei and amphiphilic cytoplasm is noted. There are some common architectural patterns of pin which include flat, tufted, micropapillary and cribriform patterns. In flat pattern, there is 1 to 2 layer of simple epithelium. In tufted pattern, there is stratified epithelium with small luminal protrusions. In micropapillary pattern, there is filiform structures which lack the true fibrovascular core, and in cribriform pattern, epithelial proliferation with punched out spaces are noted. In contemporary practice, most experts report such proliferations as atypical intraductal proliferations, suspicious for intraductal carcinoma of the prostate. Here I have shown images of flat high-grade prostatic intraepithelial neoplasia and tufted high-grade prostatic intraepithelial neoplasia. Talking about the term intra-acinar carcinoma or intraductal carcinomas, these are neoplastic epithelial proliferation that has some features of high-grade prostate intraepithelial neoplasia but exhibit much greater architectural or cytological atypicia typically associated with high-grade of prostatic carcinoma. I'll repeat this once more so that you understand it nicely. Intra-acinar carcinoma or intraductal carcinomas are neoplastic epithelial proliferation that has some features of high-grade pin but exhibit much greater architectural or cytological atypia typically associated with high-grade and high T stage of prostatic carcinoma. The term low-grade prostatic intraepithelial neoplasia term is not used now. And cribriform subtype of high-grade prostatic intraepithelial neoplasia is no longer recognized as a distinct entity as it belongs to a group of intraductal proliferations that are more complex than high-grade PIN but less complex than intraductal carcinoma. Now coming to the Gleason grading. Well, Gleason grading is based on the architecture of the tumor. There are 5 patterns in Gleason grading, and then there are grades of Gleason grading. These grade can be grouped as 1, 2, 3, 4, 5, and Gleason score is calculated using the primary and the secondary architectural pattern. For example, if there is Gleason grade if the Gleason score is 3 plus 3 or is 6, then it is categorized as grade group 1, and this cancer has low risk as it is usually slow growing and less likely to spread. When the Gleason score is 3 plus 4, 7, then the grade group is 2 and it has intermediate favorable risk and the cancer can be moderately like to spread. When the Gleason score is 4 plus 3, 7, again it is grade 3 and intermediate unfavorable risk. The cancer can be moderately likely to spread. When the Gleason score is 4 plus 4 is equal to 8, high risk is there and the cancer can be fast growing and more likely to spread. And when the Gleason group is 5 or grade group is 5 and the Gleason score is 9 or 10, there is highest risk of the cancer to be spreading fast and it is very likely to metastasize. Always remember that the Gleason score is calculated by the primary pattern number and the secondary pattern number. For example, if the primary pattern is pattern 1 and secondary pattern is pattern 2, then it is calculated as 3 Gleason score. Similarly, if the primary pattern is pattern 3 and the secondary pattern or the less common pattern is pattern 4, it is calculated as Gleason score 7. I hope you have understood the Gleason grading well. The other types of carcinomas which are encountered in prostate are squamous carcinoma, adenosquamous carcinoma and adenoid cystic carcinoma. However, these are rare tumors. Coming to the treatment of prostatic adenocarcinomas. Well, the treatment is based on Gleason score and grade, tumor volume, tumor extent, PSA level, patient age and comorbidities. Generally, radical prostatectomy is sufficient for treatment. Some patients require radiation therapy and androgen deprivation therapy. Earlier, bilateral orchiectomy was done for androgen deprivation therapy, but now LHRH or luteinizing hormone releasing hormone agonists are given, which decrease the testosterone production by testes and leads to remission. The 15-year survival rate is generally more than 90%. When the prostatic tumors metastasize, they produce osteoblastic metastasis in the bone, and PSA levels can be done to monitor the response of the treatment. I hope you have understood the morphology of prostatic adenocarcinoma and Gleason grading very well by now. It is very commonly encountered in day-to-day practice to get a prostatic biopsy, which could be a needle core biopsy or whole radical prostatectomy specimen. I hope this video will help you solve the case nicely. Thank you.